So we're in chapter 14, Biostatistics, part 8. So we have about 2.5 pages, starting on page 219, of charts that we're going to go through. And we're going to look at the benefits of the different types of studies and limitations. So let's start with looking at, on middle of page 219, we have our case control studies. So this will compare patients with a disease or cases of these patients to those that do not have the disease, which would be the controls. The outcome of the cases and controls is already known, but the researcher looks back in time retrospectively to see if a relationship exists between the disease, the outcome, and various risk factors. So some of the benefits of this type of case control study, the data is easy to get from a patient's medical records. It is good for looking at outcomes when the intervention is unethical. So for example, exposing a patient or patients to a pesticide to test an association with cancer. Cases that occurred are used instead. Also, case control studies are less expensive than trying to set up a randomized controlled trial or RCT. Some limitations of case control studies would be cause and effect cannot reliably be determined. Associations may be proven, but associations may be proven to be non-existent. So let's go to the other column where we look at the example for this case control study. So let's see, there's an example here, predictors of surgical site infection after open lower extremity bypass, LEB revascularization. So the methods, data was pulled from 35 hospitals for all patients who had LEB, the lower extremity bypass, during a 3-year period. Cases of surgical site infection, SSI, were identified and compared to those who did not develop the surgical site infection, SSI. Those were the control patients. Then an odds ratio was calculated, the OR was calculated for various risk factors that might increase the surgical site infection, SSI risk. So that was methods. Statistical data. So we have renal failure odds ratio. We have a hypertension odds ratio, and we had a BMI odds ratio calculated. They all had 95% confidence intervals. And the conclusion was for renal failure, hypertension, and BMI greater than or equal to 25 kilogram per meter squared, these 3 outcomes were all associated with an increased risk of surgical site infection, SSI. So we're going to next look at cohort study. So let's see. This compares outcomes of a group of patients exposed and not exposed to a treatment. The researcher follows both of the groups prospectively in the future, or retrospectively would be less common, to see if the patients develop the outcome. So what are the benefits of a cohort study with exposed and not exposed to treatment? So in terms of benefits, it's good for looking at outcomes when the intervention might be unethical. Limitations, it's more time consuming and it is expensive. more expensive than a retrospective study. Another limitation, it can be influenced by confounders, which are other factors that affect the outcome. Examples might be, could be affected by lipid levels or smoking. So let's look in the next column at the study type example. We're looking at cohort studies. So the example is statin use and cognitive function in adults who have type 1 diabetes. The methods, so the patients with type 1 diabetes who were taking statins, those were exposed to the statin, were compared to those patients that had type 1 diabetes that were not taking statins or not exposed. These patients were followed in a cohort study for 7 to 12 years to see if statin use was associated with cognitive impairment. So that's the outcome that they're trying to measure. Statistical data. Statin use and odds of cognitive impairment had an odds ratio calculated with 95% confidence interval. This cohort study concluded that in type 1 patients, patients with type 1 diabetes, patients taking statins were more likely to develop cognitive impairment compared to those who did not take statins. All right, so let's move on to page 220. And we're going to look at top of page 220, we're looking at cross-sectional surveys. So these surveys will estimate the relationship between variables and outcomes or prevalence at one particular time, cross-section in a defined population. Benefits. So you can identify associations that need further study, and this would be hypothesis generating. Limitations. Does not determine causality. Further studies would be needed if an association were found. So let's look in the next column at a cross-sectional survey example. Example, association of SSRIs, selective serotonin reuptake inhibitors, and bone mineral density, BMD, in elderly women. Methods. A cross-sectional analysis of 250 elderly women, that's our defined population, from August 2010 to April 2015, that's our time period, was performed. Data was collected retrospectively for the two groups. The SSRI users was a variable, SSRI non-users was another variable, to compare the prevalence of low bone mineral density. Statistical data. No difference in the prevalence of low bone mineral density at the femoral neck or the spine. Conclusion. There was no difference in the prevalence of low bone mineral density between elderly women that were taking an SSRI and that were not taking the SSRIs. All right, so we're continuing on page 220. We're going to look at case report and case series. So let's look at what this is. So a case report or a case series describes an adverse reaction or a unique condition that appears in a single patient, like a case report, or a few patients' case series. The outcome of the case in each of these is already known. A case series is more reliable than a case report. So benefits can identify new diseases, drug side effects, or potential uses. Another benefit generates hypotheses that can be tested with other study designs. Limitations of case report and case series. Conclusions cannot be drawn from a single or few cases. So let's look at an example for case report and case series. So let's look at tardive oculogyric crisis during treatment with clozapine. Report of 3 cases. Methods. A psychiatrist identified 3 cases of patients at his center who experienced the adverse effect, wrote it up, and it was printed in a medical journal. Statistical data. There was no statistical validity. Risk cannot be compared to the general population as there is no control. Conclusion. The findings of oculogyric crisis in patients treated with clozapine are interesting, but they do not provide important information on prevalence. All right, let's go to the next part. We're still on page 220. We're going to look at randomized controlled trial. So randomized controlled trials, RCTs, they compare an experimental treatment to a control or placebo or existing treatment to determine which is better. Subjects within the desired characteristics or inclusion criteria are carefully selected, and patients with characteristics that may influence the outcome are excluded. That would be the exclusion criteria. Patients are randomized. They have an equal chance of being assigned to the treatment or control group, sometimes blinded, unaware if they are receiving treatment or control. Some common types of blinding designs include a double blind, where both the patient and the investigator are unaware of the treatment assigned. A single blind, the patient is unaware of the treatment assignment, but the investigator is aware. Open label or unblinded, all parties know which treatment is being given to the patient. So what are some benefits of randomized controlled trials? This is the preferred study type to determine cause and effect or superiority. Benefit also includes there's less potential for bias. Some limitations of randomized controlled trial would be they're time consuming, they're expensive. Also another limitation is that it may not reflect real life scenarios when rigorous exclusion criteria are used. So let's look at the next column where we have the randomized controlled trial example. So we have angiotensin neprilysin inhibition versus enalapril in heart failure, the paradigm heart failure study. Methods. Patients with heart failure were randomized in a double-blind manner to receive a new drug, the angiotensin neprilysin inhibitor, or the current standard of care, enalapril. The effectiveness of the treatments was measured as a primary composite outcome of death from cardiovascular causes or hospitalization for heart failure. Statistical data, the primary outcome hazard ratio was calculated at 95% confidence interval, and the conclusion was that the new drug demonstrated a statistically significant benefit in reducing death from cardiovascular causes or hospitalizations due to heart failure. The null hypothesis that there was no difference between the two arms was rejected. And then the bottom of page 220, a parallel randomized controlled trial for study type. So this is where subjects are randomized to the treatment or the control arm for the entire study. So then an example was in our paradigm heart failure study discussed above. It is an example of a parallel study design and is the most common type of randomized controlled trial. Then page 221, there could be a crossover randomized controlled trial where patients are randomized to one of two sequential treatments. There could be a group 1 and a group 2. So like in group 1, they would receive treatment A first, then cross over and change to the treatment B. In group 2, they might receive the treatment B first, then cross over and change to treatment A. So what are the benefits of this? So the benefit would be that the patient serves as their own control, and this would minimize the effects from confounders. Limitations: a washout period is needed to minimize the influence of the first drug during the second treatment. So let's look at an example of a crossover randomized controlled trial. So the crossover comparison of timolol and latanoprost in chronic primary angle closure glaucoma. Methods: patients with chronic primary angle closure glaucoma were randomized after surgery to latanoprost or timolol. 3 months after treatment with the first drug, the second drug was substituted. The intraocular pressure, or IOP, was recorded before starting at 3 months, 7 months in both groups. Statistical data: decrease in intraocular pressure from baseline, and we have the data listed there. So the conclusion was that based on this data, that latanoprost was associated with a greater decrease in intraocular pressure from baseline than timolol. Moving on, page 221, we're going to look at factorial design. So this randomizes to more than the usual 2 groups to test a number of experimental conditions. Benefits: so this evaluates multiple interventions, so multiple drugs or dosing regimens within a single experiment. Some limitations of the factorial design: within each arm that's added, more subjects are needed to have adequate power for the study. So here's an example of factorial design. Prednisolone or pentoxifylline for alcoholic hepatitis. Methods: so a 2x2 factorial design was used to evaluate the effect of prednisolone or pentoxifylline on a 28-day mortality in patients with alcoholic hepatitis. Patients were randomized to one of 4 groups. There would be prednisolone, pentoxifylline, so PR, placebo, PR, PE is one group, the PR placebo is a second group, PE placebo is a third group, and then placebo is the 4th group. So statistical data, we have our data here with our odds ratios calculated at 95% confidence intervals, and it concluded that pentoxifylline alone or in combination with prednisolone and prednisolone alone did not reduce mortality in patients with alcoholic hepatitis. And then we have 2 more study types we're going to review. We have our meta-analysis, and then we have our systematic review article. So for meta-analysis, this combines results from multiple studies in order to develop a conclusion that has greater statistical power than is possible from the individual smaller studies. So again, to review the benefits of meta-analysis, smaller studies can be pooled instead of performing a large, extensive study. See previous forest plot explanation for how the data can be presented. Limitations of the meta-analysis: the studies may not be uniform. So we're looking at size, inclusion, exclusion, criteria, etc. Validity can be compromised if the lower quality studies are weighted equally to higher quality studies. So let's look at the meta-analysis example. So studying antioxidants for chronic kidney disease, CKD. The methods. The author searched the PubMed database to locate studies investigating the use of antioxidants in people with chronic kidney disease. 10 studies were identified, and the results were pooled to determine whether antioxidants had an effect on cardiovascular disease and mortality in patients with chronic kidney disease. For statistical data, it looks like the RR was calculated. So we had the antioxidant use and cardiovascular disease, RR. We also had the all-cause mortality, RR, calculated. Both of those calculations were at 95% confidence. And the conclusion was that antioxidant did not reduce cardiovascular disease or mortality in these patients with chronic kidney disease. The last study type is the systematic review article. This is a summary of the clinical literature that focuses on a specific topic or question. So for example, we have treatment options for a condition. This begins with a question followed by a literature search, then the information is summarized and sometimes includes a meta-analysis to synthesize results. What are the benefits of the systematic review article? Well, it's less expensive because the studies already exist. So let's go over one example and then we will pause. So the example here, the evolving treatment landscape of advanced renal cell carcinoma, RCC, in patients progressing after VEGF inhibition. So the methods. It is still unclear which patients benefit most from VEGF or mTOR inhibitors, and the ideal sequence, the ideal timing, and the ideal duration of therapy. The review wanted to define the appropriate treatment sequence after first-line treatment failure. So for statistical data, there were no statistical tests reported. The conclusion was that there are no predictive biomarkers that determine the best therapy for the right patient or the best sequence of treatment. More studies will be needed. That's page 221, and we're going to pause there.